Can you hear me?
Yes, we can. Yeah, good.
So thank you very much. Vikas asked me to talk very specifically about what he calls the technical aspects involved in COVID-19. So, and given that Prabir and Indranil will be talking, I'm sure that a large number of public health systems and policy related issues, as well as associated issues of intellectual property and how those considerations have shaped the global response to specifically to the pandemic, will inevitably come up, coupled to Comrade Sindhu's much more grassroots perspective on experiences in the pandemic. Let me say something about very quickly as background for the pandemic. It is not good for us to be treating it as an indivisible, ununderstood whole while we consider its effects on socio-political systems at large. So I'm going to divide these comments into three components. One is going to be about infection and its spread. The second is going to be about disease and its management. And the third is going to be about vaccines and prevention. And all of those three I'm going to talk about, faithful to Vikas's instruction, in the technical issues involved rather than the socio-political ones. So let me start with infection. Clearly, we have a viral infection that is transmitted through the air based on infected people putting out water droplets through sneezing, through coughing, and so on and so forth, water droplets into the air, and those being breathed by uninfected people and acquiring virus infection. Now, there are a couple of points about this that I would like to point to. One is the quite curious kinds of health policy responses that we have watched through the year with respect to what in retrospect should have been self-evident. First, the extraordinarily cautious early responses from global health and disease leadership that expressed great doubts about whether masks, in fact, would cut down on the speed of spread of the infection. You would think that this is a no-brainer, and yet it clearly wasn't. And it's interesting to speculate on the socio-political background of why this was apparently not a no-brainer. Secondly, let's get a little bit technical, where droplets of water come out of my nose or my mouth and I'm infected, and it will be obvious to everybody once I point it out that large droplets of water, large droplets of fluid, that come out will have two contrary characteristics as far as spread of infection is concerned. Each droplet, because it's large, will be carrying many more viruses, virus particles, than a very small droplet would. On the other hand, so its infection potential is greater, droplet per droplet. Large size droplets will have more potential than small size droplets. On the other hand, when I cough, large sized droplets will fall to the ground much quicker over a much smaller radius as compared to small droplets, which in the very small droplet region, which is generally called the aerosol part of the spectrum, will stay suspended in the air for much longer and therefore can be breathed in over a much longer distance and a much longer period of time. Under those circumstances, you can imagine that large and small droplets are likely to play different roles as far as the spread of infection is concerned. And I bring this up in a very specific, let me contrive it as a contrasting set of situations of spread. One is in the hyper-crowded, communal living, working class, urban localities of India. The hutman colonies, the Chukki Jhopdis, as we insist on referring to them, where in literal adaptation from Kabir, the virus is present sab sanson ki saans mein. Because people are living communally, everybody is rubbing shoulders and exchanging breath with each other. Large droplets become a way of exchanging infection. On the other hand, in the winters of temperate and subtropical regions, where people are living primarily indoors, particularly in communities such as university dormitories and so on and so forth, what is being done is heated air that is recirculating. You're going to have the really small droplets, whose, let me use the space science term, payload of viruses is much smaller than that of a large droplet. And therefore, if you are exposed to one aerosol droplet, that's a relatively small amount of infection. In the open air lives that India lives, aerosols will disperse and dilute, but in the recirculating air that winters in the temperate and subarctic regions, you will be exposed to the same aerosol droplets over and over and over again. You can therefore imagine that depending on socio-geographical circumstances, the modes of spread of the virus can differ. For this, again, not to be acknowledged in its comprehensive complexities, but simply to come down to, are masks useful? And Europe and North America thinks either that they are not useful to begin with and are useful subsequently, or is aerosol transmission important? And for them to think, no, it's not important because they are in their summer, and then to think that, yes, of course, they are important. All of this points to a certain socio-political contexting of what appear to be purely technical issues. So that's one set of issues about the spread of infection that I think it's interesting to keep in mind in the particular context of looking back at a year of the pandemic from primarily a social science perspective. The second point about infection that begins to border on disease that I would like to point to is that we need to be able to separate infection and disease. Infection is when a virus payload lands through a droplet on the back of my throat, and individual virus particles stick closely enough to cells that are lining my throat as to be able to introduce the viral code into the cell. The viral code takes over the biochemical machinery of the cell and diverts it from maintaining cellular function to putting many virus particles together. And once those virus particles are assembled, the cell breaks open, the cell releases virus particles, and you set up accelerating, expanding spheres of infection locally. So this is infection. As cells get infected and make more and more virus particles, the body responds by attempting to contain the virus infection to those points and uses the dreaded so-called cytokines to build containment zones in the back of the throat or lower down in the airways. However, in a certain sense, the fact that cells lining my throat have been infected already allows the virus progeny, the thousands of virus particles that can come out of one infected cell, one cell infected by one viral particle, those particles already to be coughed or sneezed out, and therefore to be transmitted. In effect, therefore, even if I am, as an individual, quite successful in containing the virus infection by maintaining micro-quarantine zones in the back of my throat until my immune system can mop up the virus and so on and so forth, no or very little by way of symptoms and signs of illness have been felt, I have still been transmitting virus. So we need, therefore, a clear distinction between success of infection from the virus's point of view and the illness that individuals feel. And we don't always make this distinction. Most recently, we are failing to make this distinction in the public discourse on, oh, we were told that children cannot be infected, but now we are seeing that in schools after schools after schools, particularly in the high-end schools of Calcutta, children are getting infected. How is this? Is this a different virus? And the resolution is that we have never thought that children cannot be infected with the virus. Our understanding over the past year is that even when they are infected, children don't seem to be particularly severely sick with the virus. There are exceptions to this, but at a statistical level, the proportion of children becoming severely ill with COVID-19 is much lower than the proportion of, say, the elderly. We're not making the distinction between infection and the successful transmission of the virus, which maintains the virus in communities, from the ability of the virus to create illness in individuals, which leads to a whole different set of important outcomes. Ill health, the resulting loss of income and livelihood, as well as, of course, the demands on specialized secondary, tertiary, and indeed quaternary medical care, and the availability of systems that provide that. So these are, in my eyes, absolutely critical issues when we begin to think about the infection, when we begin to think about the illness. Let me say one more issue about infection and illness. The virus is making its own copies using the cells of our body. Every biological act of copying carries the possibility, the statistical possibility of error. As a result, every progeny virus particle is a genetic variant compared to the original virus particle. By and large, this sort of shotgun spray of variation has no real consequences. But what it provides is a landscape of diversity in the population, is a highly diverse population, where if there is a selection pressure exerted, then specific variants with specific properties, characteristics, traits will selectively survive and will therefore come to represent the major virus population. And let me give you one example of how that has shifted over the past year. The major anti-transmission policy that we have all adopted, variably, depending on whether you are the USA of Donald Trump or the Brazil of Bolsonaro and so on and so forth, has been physical distancing. I am very reluctant to use the phrase social distancing for obvious reasons in the subcontinent, physical distancing. And as far as physical distancing is concerned, the argument from the virus biology perspective is straightforward, that if you maintain physical distances, then transmission becomes that much more tenuous. The variants of the virus that will therefore gain an advantage when we are maintaining physical distancing are the variants that will provide the virus with a better likelihood of establishing infection. Now, I pointed out that the virus sticks to cells and injects its genetic code into cells. If the sticking, which is through the spike protein of the virus, which is what gets talked about all the time, if the sticking is highly efficient, if the sticking is very potent, then infection will be very good. And therefore, the possibility of infection, establishing good infection per virus particle will go up. And therefore, the so-called UK variant, which I'm very reluctant to call the UK variant, so I will insist on calling it the B117 variant, which has a stickier spike protein, is becoming successful across the world. In fact, stickier virus particles are the primary variants that are surviving. And they are the direct result of the fact that we, the world over, are to varying degrees attempting to maintain distances. And that brings me to my last component, which is the vaccines. The issue is not whether we can or cannot generate immune responses to the virus or not. We can. Even all of us who have not been exposed to the virus will generate effective immunity against the virus. As I said, when the virus lands, immune responses will attempt to contain it. Immune responses will attempt to make specific targeted responses against the virus. Even after we've recovered from the infection, we will continue to hold those immune responses, which is why we are even better protected if we have had either a natural infection with the virus or if we've been vaccinated. And on this background, the vaccines. So what are vaccines representing? Vaccines are representing a mimic of the virus. And the mimic that all available current vaccines against COVID-19 are maintaining is the spike protein, because if I can generate antibodies against spike protein, those antibodies in my body, in the fluid in the back of my throat, will prevent the virus particle from sticking closely enough to cells to prevent infection. So can I generate high concentrations of potent preventing protective antibodies? All of the current vaccine designs are essentially doing this. The vaccine designs are being divided into two categories of platforms. One category is where the genetic code for the spike protein of the virus is being injected into the body, allowing the body to make the protein and to generate an antibody response against it. And the mRNA vaccine from the NIH Moderna stable, the BioNTech Pfizer vaccine from the, both of which are the mRNA vaccines. The Zydus Cadila vaccine that is in clinical trials in India is instead a DNA-based vaccine. And all the adenoviral vaccines, the so-called Gamaleya Sputnik 5 vaccine, the so-called Oxford AstraZeneca Serum Institute of India vaccine, use a viral vector of a harmless virus, the adenovirus, or different kinds of adenoviruses, to provide the body with the genetic code to make the spike protein and to respond against it. There is a whole separate, more traditional category of platforms, such as the Novavax one, or such as the ICMR Bharat Biotech one. I have very deliberately not mentioned the entire stable of Chinese vaccines, which span this whole spectrum of technological platforms. And it is remarkably interesting to ask how these technologies are being deployed, how manufacture is done, and how implicit as well as explicit marketing is done. So at the moment, all vaccines are under emergency use authorization, which means that their safety trials have been done as they normally would be done for any biomedical product going into communities. Their efficacy trials, however, have not been completed, and therefore they are under emergency use authorization because they have only very preliminary data. Those preliminary data do not allow anybody to say my vaccine is better than your vaccine. Yet that's a conversation and discourse we find in very large amounts across the world between vaccines. And it is this scenario of the private sector, the private profit-making sector, developing, deploying, and at least implicitly marketing vaccines, that I think is remarkably interesting as far as looking at both efficacy of vaccination campaigns is concerned and vaccine pricing is concerned. That, I think, is the technical background of what I think infection, disease, and the vaccines need to be thought through. I will therefore, I apologize, I've taken longer than I ought to, and I will stop there. And I will, of course.
Thank you, Sachin.